Bismillah ar-Rahman ar-Rahim. I'm very happy for the invitation and good morning for all. I'm speaking today about the decision to fish or not to fish or when to fish. I will begin my presentation with this old video. This is a case was sent to me since about 10 years, I think. Here the anterior segment surgeon had dropped the nucleus. That's nothing we have every day. This is the everyday procedure we have. But the problem here is he tried to fish for the crystalline lens. While fishing of the crystalline lens, While fishing for the crystalline lens, he fished the retina itself. So we have a large retinal break from the scoop. So he opened the wound. First of all, he fished very much. He fished the vitreous and he fished the retina as we saw, leaving the retina with a large retinal break. These situations make the mission of the posterior segment surgeon very hard to correct. At the same time, it's very hard for the patient to have a good result. So any situation like this, let it rest in peace. Don't never and ever fish for the dropped lenticular part, whatever happens. And this is the break as we saw in the video. This is a large break. This is the laser around the break, and after removal by the phaco-fragmentation of the crystalline lens, I started to put the silicone oil tamponade, and this patient, for his bad luck, was a driver. And this is the endo-iridotomy, and this is the silicone oil we put it, and this is the old 20, the sutureless, trocarless 20 gauge vitrectomy. So there is risk factors. We should take care of these risk factors. Inability to lie flat, trainee surgeon, glaucoma, reducing pupil size, pseudoexfoliation, high myopia, traumatic cataract, phacogenesis, tamsulicine, the treatment of prostate, white cataract, increasing age, the complicated fellow eye surgery, eyes with transillumination defects in the iris, and the previous vitrectomy of the eye. All these signs are risk factors for this condition, dropped lenticular part. We have ominous signs when to doubt something is going wrong: tilting during the operation, tilting the lens equator, loss of the ability of rotation, sudden deepening of the anterior segment. These signs deserve immediate attention. Please don't fish. The guidelines to the anterior segment surgeon in this situation: you can do retrieval only if fragments are visible. No fishing, whatever you see or you are seeing the particles in the anterior vitreous. This is a parallax. Never do it. Perform anterior vitrectomy. You can insert the IOL and standard wound closure, and you can refer after that. Another case, we are going to fish in this case. This is cataract surgery since 2 years, developed endophthalmitis. I did the vitrectomy for him since 2 years, and I didn't remove the IOL. He came to me for insertion secondary IOL. While the patient was on the table, I saw a shadow under the iris, and I didn't know that there is the IOL. This patient wasn't seen by me at the first, so I didn't document that I put an PC IOL. While the patient was on table and I was going to put iris claw lens, I found a small shadow under the iris as we saw in the video. So it was the previous IOL. So I get the IOL like we are seeing together, and I put it in sulcus, centered, and I wasn't in need to put either a new IOL or an iris claw IOL. And the patient, after the operation, he told that he has a trauma in his eye, but he doesn't remember this well. and this is the final. Of course, I am putting a trocar with infusion because this is vitrectomized eye, so I can go without hypotony. The last case, this is a Marfan syndrome. This is a child with bilateral subluxated cataractus lens. So I did him in the first procedure, as we see, remove the cataract. Then I put the artisan. This is artisan iris claw lens. When you decide to put the artisan retropupillary, you should put it upside down, as I showed in the video, to put it in the right place, and try always to mark at 0 and 180 before the patient sleeps in the OR. Everything went good. As we see, centralized, I am seeing the dimples of the iris. The patient came for me after that without the IOL. I looked thoroughly in the fundus. I didn't find the IOL, so I'm trying to fish where is the IOL. It's impossible that the IOL had removed from the eye, from the trauma or something like that. So I tried to fish for the IOL. The patient had vitrectomy before, so there is no vitreous while I am fishing. This is an important thing. The key here that I am seeing a dimple at the temporal side of the iris, but I am not seeing where is the IOL. And finally, the IOL was reflected on the ciliary body. So I tried to manage the IOL to get it, to dissect it from the back of the iris. And after I get it out, I put it again retropupillary, as we are going to see in the video, like this. These cases, usually we should put the infusion to prevent hypotony, and I opened only one site. I didn't put two trocars, just one site to get the IOL, and at the end of the surgery the IOL is centered, and I removed the trocar away. Thank you very much, and it's my honor to invite all of our colleagues to the next AVRS meeting, 10 to 11 September 2026. Thank you very much.
Thank you very much, Dr. Muhammad. So returning back to the title of your presentation, if any anterior segment surgery is faced with the problem of dropped nuclear fragments, what do you recommend for him to do? Would you recommend inserting an IOL before removal of the nuclear fragments which has escaped in the vitreous, or not, or to defer it for another intervention?
I recommend in this situation never to fish for the fragments, to do a proper anterior vitrectomy, and if there is a good anterior capsule, he can put a 3-piece IOL and defer the patient after that to vitreoretinal to remove the dropped nucleus or the dropped lenticular parts.
So in case the drop is not a nucleus but a dropped IOL, would you recommend inserting another IOL and referring it to a posterior segment surgeon, or just not to,
yes.
to insert?
If the dropped, if it's a dropped IOL, just leave it. No need to put extra IOL. So it will be very hard for the vitreoretinal surgery to remove the fell IOL and put a new one. So if there is a drop IOL, just leave it.
Dr. Muhammad, in your first case, I saw that the patient was affecting the large retinal break, and you put silicone. What was your precautions to prevent the silicone from damaging the cornea?
Yes, I put. I did endo at the end of the surgery, endoirodotomy, and if it's a good fill, there is no any fear from this.
Iris claw lens to prevent the connection between the posterior and the anterior segment in these cases?
There was no iris claw lens at that time.
Okay.
Yes, we didn't have only ACIOL, but I deferred I put ACIOL, but after I removed the silicone after that.
Okay. In the last case, I found that you did the iridotomy. In the second time, you put the...
Yeah, I did it in the first time, but it closed.
Mm-hmm.
So I made a new one.
Okay, nice case, by the way.
Thank you.
ألف شكر دكتور محمد على البرزنتيشن الجميلة. بس حضرتك بس الحالات والدكتور مجدي والناس والاودينس، حالات اللي هي اليونج ايج اللي هم الهايلي اكتف، اتس بيتر ان انا احط الايريس كلور لينز انتيريورلي وبوستيريورلي. الحقيقه كان ليا تجربه، واحد هايلي اكتف بيلعب كوره، بيلعب الكوره بالهيد، قال لي انا لعبت الكوره بالهيد جبت جول ما شفتش. ففعلا يعني ساعات المور سيف في الهايلي اكتف فيجن ان احطها انتيريورلي على الايريس، مش احطها ريترو بيبيلري. ما اعرفش راي حضراتكم في النقطه دي ايه.
نسمع رأي دكتور مجدي وانا بقى اعلق في الاخر.
I have seen cases of dropped artisan lenses put anteriorly and posteriorly. I usually don't like very much these lenses, but it can drop once the fixation of the iris to the haptic of this lens gets loosened. It can drop from either anterior or posterior condition.
اعتقد posteriorly much more higher than anteriorly. يعني
Possible.
I want to comment on this because in the iris claw lenses in the young patients, definitely they move with moving the eyes. So this patient will have a corneal decompensation in 10 or 20 years. So I never put it in the anterior segment. I put it always posterior.
Yes,
Even if it dropped, I put it posterior.
Yes, I go with Ahmed, Dr. Ahmed Mutwalli in this idea. I always put the iris claw lens in young patients and in children if I was in need to put it retropupillary, and if it fell like this, I put it also retropupillary to keep the cornea, because he or she has a long life expectancy.
But I have a comment. First, when I put a PC claw lens, I don't need to do iridotomy.
You don't need
No, never. And I never face a complete retropupillary, yes.
because the surface is concave in this
Yes,
part, so
yes.
you can listen.
And also I never had a retropupillary dropped.
I have seen dropped
I have many
and,
cases drop. دكتور طارق كان عايز يسأل سؤال. اتفضل دكتور طارق.
Let me ask you a question. Are we abandon using anterior chamber IOL, or we're still using them?
I use anterior chamber IOLs, especially in old people. This, to my mind, decreases the incidence of corneal problems after inserting it. However, I have seen in my cases after 10 years, 15 years who developed corneal problems after anterior chamber IOL.
حضرتك موضوع الكورنيا الاندوثيليا في حالات السكندري اويل ايذر ارتيزان او حتى ياباني تكنيك، المشكله كلها ان دي اصلا كومبليكيتد كاتراكت سيرجري وديفرنت مانيبيوليشنز. هم بيقولوا ان غالبا المشكله في الاندوثيليا مع اللونج تيرم ان حصل مشكله في الكاتراكت سيرجري، فحصل الاندوثيليا سيل كاونت قل. مالوش علاقه قوي لا يعني مثلا في الياباني تكنيك وفي في الارتيزان اي ال الاندوثيليا سيل كاونت في الليترشر بيقولوا انه ازيد من العادي، لكن السبب هو الكومبليكيتد كاتراكت سيرجري، واللي هو اكتر في الحالات اللي هي مثلا فيها سكندري او ال. كل ما بتعمل مانيبيوليشنز اكتر في السيرجري بتلاقي المشكله اكتر. فالموضوع ملوش علاقه قوي
بس احنا كنا بنستخدم
ريتروبيوبيلاري والاندوثيليا بعيد عنها خالص. فاعتقد على اللونج تيرم هو المانيبيوليشن مش العدسه نفسها.
كان في فتره من الفترات يا اسامه بنستخدم الارتيزان as a refractory solution anterior to the lens، فدي برضو كان بيحصل فيهم مشاكل. اتفضل.
I want to comment for Dr. Osama about his comment. Lifetime OCT, anterior segment OCT, shows while moving your eyes, the edges of the anterior chamber IOL, the edges of the haptics of the iris claw lens, they hit the back surface of the cornea during just moving your eyes. It have been pictured by the anterior segment OCT live. So each movement of the eye, there is a hit for the endothelium.
Okay. Thank you very much.